So most people fear neurology, but within neurology, I think most people fear encephalitis. They don't know what is going on. The patient is confused, they're psychotic, they're screaming, they're seizing. It's an emergency. And because the differentials are so broad and they include infectious and autoimmune, you don't know where to start. You don't know what to treat. You don't know where to move from there. And I think this is a realistic fear that most people have. And I really had that fear for a very long time. Now, my name's Prashant. I'm a neurologist, and specifically within that, I'm a neuroinfectious diseases specialist and a neuroimmunologist. And my specialty area is encephalitis, so I love this. And what I want to teach you today is essentially a masterclass on how to think about infectious encephalitis, how to narrow down your differential diagnoses, and then move forward in terms of planning how to actually investigate and treat the patient. So this is going to be part of a larger series of a masterclass in neurology as well as neuroinflammation. Today we're just going to do this off my laptop because frankly I'm on holiday and I ain't got time for a studio. So let's start off. So the things I want to talk to you about today is infectious encephalitis, and then I want to touch briefly on metagenomic next-generation sequencing, and kind of a bit of a hot topic in the neuro ID world. Well, it's been around for a while, but what is it? It keeps popping up. How does it work? What's the technique? And is it appropriate? And really what I want to also go into is creating differential diagnoses, and then understanding based on your differential diagnoses, what are the appropriate tests to send. Now, the syndromic framework I'm going to talk to you about are rules of thumb. They're not 100% perfect. So obviously think broadly and don't just stick to these differential diagnoses. Okay, so what is a syndromic approach? So we like to keep things simple. Neurologists are simple people. And when you see a patient and you see an MRI scan, you can then say, wait, this fits a particular syndrome. Based on this syndrome, I can narrow down my differential diagnoses. And that's important in neuroinfections, and that's because when you have an infection, there's a broad range of pathogens. You've got bacteria, you've got viruses, you've got fungi, you've got amoeba. And within this spectrum, not all of them cause infections of the brain. There's only a subset that do. The reason a subset of infections cause neurological involvement is because of what we say is neurotropism. Essentially, the pathogen has the ability to invade the brain and the neurons based on a specific tropism, a molecular pathway, and in kind of a way of getting into that actual neuron. Certain pathogens have specific neurotropism for particular regions of the brain. Now, the brain isn't just one giant similar being. It's not one homogeneous monolithic entity. It's actually lots of different neurons that are subspecialized and lots of different aspects that are different. So a thalamus and the thalamic neurons can be very different to the neurons that are sitting in your basal ganglia. And so there is a tendency to have neurotropism based on the pathogen. So you can look at the syndrome, you can look at the MRI, and then you can say, I can narrow this down to a very particular type of infection. So I'm going to go over meningoencephalitis, limbic, subcortical white matter, deep gray in thalamus, cerebellitis, and rhombencephalitis. So let's start off with meningoencephalitis. What is meningoencephalitis? Well, meningoencephalitis is meningitis and encephalitis. There's inflammation of the meninges around the brain, and there's involvement of the brain parenchyma itself. And this has become inflamed, and so patients can have a combination of both. So if we look at this MRI scan, we can see that there's inflammation around the actual brainstem itself. This is meningitis. And this patient is obviously sick as well because they've got encephalitis. And obviously this is a masterclass, and so I'm presuming there's some level of background knowledge, but just for those of you who are very new to this, meningitis is inflammation of the meninges, encephalitis is inflammation of the brain, and when you get inflammation of the brain, you can get behavior changes, psychosis, short-term memory loss, focal neurology, so that's weakness, numbness, and then you can also get new onset of seizures. When we start seeing that, we know it's more than just the lining of the brain that's involved, because that would just cause headache, neck stiffness, light sensitivity. So in a patient who has meningoencephalitis, they have a combination of both. So let's just start off with a quick case to begin with. We've got a 75-year-old acute onset of hemiparesis. They're treated for temporal arteritis a week earlier with steroids, and then they develop a headache on the steroids and the fever, and then a right-sided hemiparesis. This is their MRI scan. This is a diffusion-weighted image. And you can see down here in the brainstem, specifically the midbrain, and specifically in the crus cerebri, which is the anterior part of the brainstem where the corticospinal tracts are traveling down. So here you can see this area of diffusion and restriction. And so this is on the left side of the brain because it's the right side of the image. So they've developed a right hemiparesis. So if we go back to our neuroanatomy section that we've been doing as well, this would cause that syndrome. But if we look at the MRI T1 with contrast, you can see this contrast enhancement all around the brainstem, and importantly as well around the circle of Willis and these blood vessels here as well. So this is T1 with contrast. If we want really good resolution of the meninges, we usually give FLAIR with contrast, and it's actually really good. But here we can see enhancement of the meninges. So we've got a stroke, and we've also got involvement of the brain parenchyma. It's not quite an encephalitis, but we're dealing with probably a vasculitis, inflammation of the blood vessels. You can see all this gunk sitting around the blood vessels itself. Now, when we think of meningoencephalitis, the three things I generally like to look at is, one, is it a basilar meningitis? And so basilar meningitis means in the brainstem, right down in the base of the brain. So if you remember, the actual basilar artery is coming up from here, right there, and this is down in the brainstem, in the base of the brain. So we call that a basilar meningitis. So this here is a basilar meningitis. The other thing I look at is whether it's nodular and whether it's thick. So nodular and thick enhancement essentially looks like this chunky looking enhancement. It's not smooth. When you see smooth, thin enhancement, it's just nice and smooth going across the gyri. Whereas here, this part's a little bigger and thicker than that part. This is thinner and then it comes a little thicker there. You can see that it's a little bit bumpy there. So we would call this a nodular enhancement. When you see thick and nodular enhancement, we think about granulomatous inflammation. That's the classic location we see it. So granulomatous inflammation is a very specific immune response. We typically think of that as a Th1 response. So T helper 1 cell response, where we're releasing interferon gamma, TNF alpha, and we're getting actual granuloma formation occurring to wall off a pathogen. And so here you can see the classic nodular thick pathogens are pathogens that trigger granulomas and granulomatous inflammation. And so we can see that we can look at basilar, we can look at nodular, and then finally I look to see if there's also a vasculitic component. Are the blood vessels getting inflamed because the blood vessels are running in that subarachnoid space? And we're causing inflammation of the blood vessels, causing a vasculitis. So if we look at this patient, we can already think this could be TB, because TB is the prototypic basilar meningitis. Cryptococcus can do it as well, and we can certainly see it in a lot of fungal infections as well as the kind of what we say is the endemic fungal infections, which we primarily see in Northern America and sometimes moving down into Central America as well. Bacterial is usually thin and linear. It doesn't give that nodular appearance. And then syphilis is the classic one there as well. And then finally, syphilis classically causes a vasculitis and meningovascular syphilis. And then we can see our other causes here as well. With bacterial meningitis, strep tends to have a little bit more likelihood of causing vasculitis because it gets under the pia mater, can really cause a lot of inflammation very cortically where the meningitis sits. So with this particular patient, we sent off for everything. We sent off for viruses, we sent off for bacteria, but you can see in this specific differential diagnosis, viruses don't actually play a huge part when we think about thick nodular basilar meningitis. You can see viruses don't usually cause basilar, nodular, or meningitis, and they don't generally cause vasculitis apart from VZV. All the other viruses can absolutely cause meningitis. So, your enteroviruses, your herpes viruses, etc. But in these narrowing down our differentials, we're not seeing that here. Now, we sent everything off for this patient. You name it, everything came back negative. She had no TB risk factors. She was elderly, so maybe cryptococcus, which we can see here in Australia, but certainly, syphilis and everything else came back negative. She had no risk factors for neurocysticercosis, which can present with a subarachnoid form as well. Now, this is where a technique like metagenomic next-generation sequencing could be helpful. So what is mNGS? Next-generation sequencing, what we do is we take the CSF or brain tissue or whatever tissue compartment we want to sequence, we extract all the nucleic acids, the DNA and the RNA. And as you can imagine, because we're taking this from a human, the vast majority of that is going to be human DNA and human RNA. And so the orange here represents human, The blue represents non-human, and the green might be the infection that's in the brain that we're trying to figure out. So metagenomics, next-generation sequencing, looks at trying to detect an infection in an unbiased, hypothesis-free manner. We're not saying, could it be this, this, and this, and send off the exact tests. We're saying, well, frankly, we don't know. We could be missing something. Let's test for everything. So we take all nucleic acid, we put what we say are adapters on the ends of the nucleic acid through a process we call library preparation. And those adapters are just oligonucleotide sequences that are attaching to the nucleic acid. These then go on to a next generation sequencer. In this situation, it's an Illumina sequencer, which does short read sequencing. So these are about 150 base pairs, but certainly there are long read sequencers that can do kilobases worth of sequencing. This is essentially a giant machine that has a chip. That chip has a glass lawn on it, this is a chip that has different lanes on it that are made out of glass. On those glass lanes are complementary oligonucleotides, where we take our library and we put it onto this flow cell, this plate, and the complementary strands will go and attach. So now it's gone from a lawn of short grass, we put our nucleic acid on, and it's like long grass standing there. And then each strand undergoes amplification, essentially in a way like PCR. And so we get these clusters of sequences that are PCR'd up, and then we add fluorescent labeled nucleotides. So every time A meets its complementary T, then the A and the T combine, and the red primer or the colored fluorescent probe is attached to it. The camera takes a picture, it cleaves off, and then we go to the next nucleic acid strand and we get the next sequence. So the machine and the camera are taking pictures of millions of strands that are being read simultaneously at the same time and moving from one nucleic base to one other nucleic acid base to the other nucleic acid base. And so in the process, the machine is reading all the strands, millions and sometimes billions of actual nucleic acid on the sequencer itself. The sequencer then computes this and says, well, this was an A because I saw a red, this is a T because I saw a green, and it gives you gigabytes and gigabytes worth of data, actual readouts of telling you what was in that strand. Now, this is the same technology where we would do whole exome or whole genome sequencing if we were looking for a genetic condition. And so here is the human genes that align to the human genome. So you take these 150 base pairs, you take it to the human genome and says, where does it fit within this human genome? And you can actually fit it there and you say, oh, that's a human read because that's 100% match between the two. That's how we would do whole genome sequencing, but in metagenomics, we remove everything that aligns to the human genome. If it doesn't align, we don't want to know about it. What we want to know about is what is non-human. We take those remaining reads, which are about 1% of the total data that's sequenced. We clean it up, we process it, we make sure that it's good quality, and we take that and we align it against every single organism that's ever been sequenced, which is pretty much everything, on a big database. And for each of those reads, it says this aligns to X genome and Y genome, and you get a readout. And essentially what you're trying to find is a needle in a haystack of what this pathogen could be based on the genetic code that's there. So in this patient, it was nocardia in the end. So you might think of nocardia as causing abscesses, and that's the most common and classical situation. But really, nocardia in very rare situations and in immunocompromised patients can cause a basal meningitis. It wasn't on my differential list because I didn't want to give it away. But essentially, anything that can cause granulomatous inflammation can cause a basal thick nodular meningitis. And so this patient ended up having nocardia species. So metagenomics in CSF came out probably, it's been a while now. So 19 was this paper in the New England Journal of Medicine, where they essentially looked at difficult cases of encephalitis, myelitis, and meningitis. So 204 patients were enrolled, and you can see 50% were unknown at the end of the day. And out of that, only 27% or 28% were infectious. Out of that cohort, conventional testing, so we're talking about PCR, serology, cultures, picked up 26 cases. Metagenomics and conventional testing as a Venn diagram. Metagenomics also picked up 19 cases that conventional testing picked up, but it picked up an additional 13 cases. And these were actionable pathogens that could change a patient's situation and trajectory, help them save their lives. Now, You can see here that metagenomics doesn't take over from conventional testing. It's not a panacea that just solves all your problems. You send the test off and that's it. So where does it fail? Where it fails in a couple of areas. One is low abundance pathogens. So think about it as a test that's really good like PCR, but if there's not enough reads to the pathogen itself, then you're not going to actually detect it. And that's classic for things like TB. TB meningitis, we see very low pathogen burden, but a huge amount of inflammation, and that's the immune response reacting and causing a lot of the damage, but the pathogen is at very low abundance. So metagenomics does poorly there. Serology-based infections, so classically arboviruses, flaviviruses, syphilis. These are tests we use serology to diagnose, not nucleic acid. We're not directly trying to identify the pathogen. We're looking at IgG and IgM titers. And so if you can imagine, why would this do poorly? Well, some infections actually are viremic for a short period of time. They're in your blood. They get into the CSF very quickly. And then after that, they go into the actual parenchyma. So they go into the spinal cord, the brain tissue. And in the process, when you're sampling the CSF, there's no virus there. It's gone. And that's why we rely on serology. Now, if we were to do a brain biopsy in these infections, we would see plenty of virus on metagenomics or direct testing methods like PCR. But you have to think, what compartment am I actually sequencing in? Now, abscesses are loculated infections, and so the pathogen and the infection are in a walled off collection. It's not circulating in the CSF. And so if you do a lumbar puncture, you're not going to pick it up. If you actually biopsy the abscess, then yes, you would be able to detect the pathogen in that way. Fungi and parasites have really thick cell walls, and so sometimes it can be difficult to lyse them and actually extract the DNA and the nucleic acid. And contamination's a big problem. So when you get the results, it doesn't look as beautiful as like just a pure nocardia. It actually can be quite complicated. There can be hundreds of pathogens there, and it could just be as simple as the resident forgot to wash their hands when they did the lumbar puncture, and suddenly there's all this skin commensal floras. And obviously wash your hand, put gloves on, gown up, things you normally do for a lumbar puncture. But even lab contamination can cause problems. And finally, it's not a cheap test, and it's costly and has expertise. But it's certainly all the buzz in infectious diseases and neuroinfectious diseases as well. And it's certainly demonstrated that it has really good benefit in lots of situations. Now, that was meningoencephalitis. Let's move on to limbic encephalitis now. So the limbic system is a region of your brain, and very simply put, is this medial aspect of the temporal lobe. It includes the hippocampus, which is short-term memory. It includes the amygdala, which is to do with kind of emotion. It can also include the cingulate gyrus as well, which is part of the cortex that wraps around the limbic system as well. So this component is very important for memory, emotion, behavior, and it's very, what we would say, epileptogenic. It can trigger lots of seizures from this area as well. So let's talk about a case. We have a 65-year-old, one-day onset, acute confusion, new onset focal seizures, and they come in, they get a lumbar puncture, and they're BioFire negative. So no pathogen there. And this is their MRI scan. So this is a very nice image to show you that we've got a flare image, and we've got this really hyper intense flare signal that's happening in the medial aspect of the temporal lobe. Can you see how that side is big and chunky compared to the opposite side? So this is what we would say edema or mass effect. It's like they've twisted their ankle, except it's their hippocampus on this side. If we look up here, this is spreading up to what we call the insular cortex. So this inner aspect here, and you see how there's cortical ribbon here. So right here is the insular cortex. So there's spread of inflammation up to the insular cortex. We're going out into the tip of the horn of the temporal lobe as well. And if you look at this coronal view, so we've cut the patient's face in half and we're looking straight in. This is the hippocampus right here, where we can see lots of edema, and it's up into the insular cortex. This is a T1 with contrast, and you can see there's a little bit of contrast just on the edge and the periphery. Not a huge amount. So what do you think the diagnosis is? The PCR was negative, but this is HSV encephalitis until proven otherwise. And I'll explain that in a second. But before we do that, I just want to quickly explain this concept of how this patient has presented. A confusion, focal seizures. This is the classic presentation of a limbic encephalitis. And so this is usually someone who presents with psychosis, confusion, short-term memory loss that's been either acute or subacute, and they've got new onset of seizures, usually focal seizures coming from the temporal lobe. So the classic temporal lobe seizures of deja vu, olfactory hallucination, gustatory rising sensation, that then can move on to motor involvement as well. So this is the classic presentation for a limbic encephalitis. Now, the LP is negative. What does that mean? Let's explain them. HSV encephalitis is the second most common cause of encephalitis, the first being Japanese viral encephalitis, but it's the most common cause of what we would say is sporadic encephalitis, whereas Japanese viral encephalitis is being transmitted by mosquitoes, etc. This is sporadic. It happens regardless of spreading it to someone else. 50% are greater than the age of 50, whereas 30% are less than 20. So we think about it as bimodal. And it's usually HSV1. So you get your cold sore, that's your HSV1, causes a cold sore. And what happens is the virus actually goes back to the dorsal root ganglia of the peripheral nerve. You have your nerve, which is your axon at the skin. It goes back axonally back to the dorsal root ganglion, which is the cell body. The dorsal root ganglion for the trigeminal nerve. From there, what happens is that it can reactivate. Now, it can reactivate forward and cause cold sores, or it can reactivate backwards and into the brain, which is where we get our encephalitis. And obviously not incredibly common, but it can happen. And it causes this acute, focal, and necrotizing. You can see hemorrhage, you can see blood with a lot of edema. And it's essentially this medial, or what we say is mesial temporal lobe. Very high rates of morbidity and mortality without early treatment. And so like we talked about, it's this classic limbic system encephalitis. Acute to subacute, fever, altered mental status. They can drop their GCS and they can have behavioral changes. And they can have focal or generalized seizures. So we do a lumbar puncture. We look for lymphocytic cytosis. So that means that the white cells are elevated. The lymphocytes specifically are elevated. And we want to do a herpes PCR. So we're doing a PCR test to look for herpes, high sensitivity, high specificity. And here's the caveat. If the patient presents too early or they present with their symptoms and you do the lumbar puncture too early, within the first 24 to 48 hours, it can be negative. So if someone presents with an MRI or a CT scan looking like that with a classic limbic encephalitis syndrome that looks like herpes, you don't stop the acyclovir. So you start the acyclovir straight away. You can do the lumbar puncture, get the PCR. If it's negative, keep the acyclovir going, and then you repeat the lumbar puncture after 48 hours, and you check again. Now, the other caveat here, which we'll talk about, is that we want to do a specific herpes PCR test. The BioFire doesn't carry super high sensitivity or specificity, which we'll go to, and this patient didn't have a BioFire. So, in a similar vein, you can get an MRI that looks very normal early on, and so we may need to repeat the MRI as well. And the MRI that I showed you is the typical kind of presentation we look at. We don't see much contrast enhancement unless there's breakdown of the blood-brain barrier, which happens with the hemorrhage or the actual edema that can occur as well. So how does that differentiate versus autoimmune versus HSV encephalitis? Now, part of the masterclass series, I will do another lecture on autoimmune encephalitis and use the same syndrome approach to come to and show you diagnoses and how to narrow this down. And autoimmune limbic encephalitis on an MRI can look very different to HSV, but sometimes they can look very similar. The three things that really help you differentiate HSV from autoimmune, and again, these are rules of thumb, so you should not absolutely anchor on this, is that HSV tends to be more acute, hours to days, whereas autoimmune is a bit more subacute, so more like days to weeks. Fever is more common in HSV, though you can absolutely get it in autoimmune. And HSV tends to be more temporal and that insular and cingulate involvement that I told you before. It's spreading up, it's expanding more than just the hippocampus itself. Now, you can certainly get bilateral HSV, you can certainly get HSV that doesn't have a fever, you can have HSV that's a little bit more slowly progressive. So don't use that as a rule of thumb to say, they didn't have a fever, therefore it's not HSV. And in a lot of these situations, you have to treat broadly with antimicrobials before you can narrow down and say, yes, this is non-infectious and let's treat as an autoimmune cause. So always, always, always consider HSV when we're looking at a limbic encephalitis. Now, what are the other causes of limbic encephalitis? Well, we think viral for a lot of these causes, whereas when we saw the basal meningitis and the nodular, we thought more bacterial and fungal. For limbic encephalitis, it's almost always herpes, 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 HSV 1, 2, 3, 4, 5, 6, and 7. Now, 1 is the most common. 2 is a little bit rarer. VZV can certainly do it. EBV more in kids and young adults, and specifically immunocompromised patients. And HHV 6 and 7 we almost only see with immunocompromised patients. Solid organ transplant, hematological, CAR T cell, it's not a common pathogen that we're seeing in the community in immunocompetent patients. And certainly you can get spurious results of HHV6 because HHV6 can be integrated into the human genome. And so patients can actually have it in their chromosome, and like people can inherit it from their parents. And so you can actually do a lumbar puncture and see low levels of HHV6, etc. And you have to match that to the clinical syndrome that we're having. So just a thing to think about. Flaviviruses and enterovirus can absolutely do it. Rabies tends to be a lot of other locations as well, brainstem, basal ganglia, but definitely can cause a limbic encephalitis. Now, syphilis, generally we think about it in a different bunch of syndromes, meningitis, meningovascular, general paresis, tabies dorsalis, but a very atypical presentation of syphilis is in a limbic encephalitis. It presents with a lot of contrast enhancement, very kind of chunky, and so we think about syphilis as well in those cases. But generally with the limbic encephalitis, for most of the infections, I'll take a travel history to look for flaviviruses or see if they have some sort of location that they've come from and make sure they haven't been bitten by a bat or a dog. But apart from that, a lot of this can be covered by an HSV enterovirus multiplex PCR. Not a BioFire, but a multiplex PCR. And by doing that and making sure that the right timing has occurred, we know that we've covered for most viral infections, and we can send off for syphilis as well. PCRs covers the differential well, but for rarer cases, sometimes we move to metagenomics as well. Timing is everything, and if you're suspicious, you keep that acyclovir going, okay? The risk benefit of keeping acyclovir running for 48 hours versus saving someone's life is obviously the benefit outweighs that. Don't exclude based on an early MRI as well. So the BioFire is essentially a commercial assay. It's a kit. It's a machine that sits there. You put the CSF in, it processes it in 2 hours. So people love how quick it is. And it does all these bacteria, all these viruses, and all these yeast, or one yeast. But what it is just a PCR test, and it's a multiplex PCR. But the problem with the BioFire, and you should always remember this, is that the sensitivities are not fantastic. So for your bacteria, we're sitting at sensitivities of 70 to 80, 90%, right? So the common thing I see is people say, oh, the patient doesn't have Listeria because the BioFire was negative. Listeria's BioFire is 70%. It's not fantastic at all. Well, PCR is not fantastic anyway. But if you look here, herpes HSV1 sits at about 80%, whereas a standard PCR that is just designed in a lab and run is up to 99%. So don't rule out an infection based on a BioFire, especially herpes, and especially ones that we can test very well for. Cryptococcus should be tested as an antigen test, not on a BioFire or a PCR. So there's so many caveats to all of this. I think it's important to understand and not just say something is negative, therefore it has excluded infection. Okay, subcortical white matter disease. Okay, so let's do another case. So here we're dealing with infections to do with just the white matter. Okay, not the gray matter, but just in the subcortical region in the white matter. So there's some sort of neurotropism for the oligodendrocytes or the axons in that region. And so we want to see what infections can do that. So we've got a new patient, he's 27, he's got NMOSD, but he's now developed new onset psychosis and progressive cognitive decline. So this was his initial NMOSD diagnosis, seronegative. He had this long, patchy, longitudinally extensive transverse myelitis. He had this brainstem lesion. He was put on rituximab and treated for that. He was on rituximab for a very long time, B-cell depleting agent. But he presents to the ED after developing new onset psychosis, 1 month after a trip to Turks and Caicos in the Caribbean. New onset, his partner says, of heavy alcohol, heavy drug use, very out of keeping for him. And so we've got behavioral changes and we've got psychosis as well. So we're already thinking, we're worried about some sort of encephalitis. And he gets an MRI brain, which is reported as stable. He gets a lumbar puncture. The protein is very elevated, but his white cells are not. And this BioFire is sent off and everything's negative. Because he's got this family history of bipolar disorder that's thought maybe this is related to first presentation of a psychiatric condition. Sent to a psychiatrist who says, after a couple of visits, this is not psychiatric. This patient clearly has cognitive decline. So we've got cognitive decline, new onset psychosis, we've got behavior changes as well. So we need to work this patient up. So he gets a repeat MRI and a lumbar puncture. And now he's got 10 white cells. So he's clearly got an encephalitis. Something is happening with the brain. and there's inflammation marked by a white cell count rise, protein elevation as well. He's got no oligoclonal bands and no IgG index in there as well. And so if we look at his MRI brain, the first thing that's striking is there's a lot of atrophy that I should not expect in a young person in their 30s. We can see all the gyri and the sulci very clearly here. And what's important as well is I can see all these white matter changes that are in the subcortical region. See it here, see it here. We can see it in the insular cortex once again here as well. And so he gets the full gamut of investigation sent off. There's a question of whether this could be part of an autoimmune spectrum. Unclear of what to do because everything's negative. He gets metagenomic sent off. Comes back positive for Coxsackie B5. What is Coxsackie B5? Coxsackie B5 is essentially an enterovirus. Enteroviruses are a large species of viruses. You've got the common cold in there, you've got polio in there, we've got Coxsackie in there, and then we've got our standard enteroviruses as well. Now, enterovirus can cause lots of neurological conditions. Depends on the strain type. So as an example, polio caused acute flaccid myelitis, as does D68. A71 causes a brainstem syndrome. So it also depends on the subtype of the actual enterovirus as well. But certainly enterovirus, and in this guy, he had rituximab with low immunoglobulins, and that hypogamma-globulинemic state increases your risk of enterovirus as well. So this patient had rituximab, unfortunately had his immunoglobulins at a low level, and ended up getting this infection. Now, the classic prototypic infection we think about with subcortical white matter is PML, and obviously this guy was treated for PML, and that first MRI I showed you at the introduction, this is classic PML. So you can see how the gray matter is not involved, there's no swelling, there's no edema. That's because the JC virus is infecting the oligodendrocytes, which are making their ability to create myelin diminish. There's no inflammation because the immune system is suppressed to actually fight it. So this is all just kind of demyelinated white matter loss that's occurring here, and that's your classic PML. So we always think about PML when we think about white matter lesions. HIV can classically do it as well. I didn't know where to stick CMV, so I'm sticking it here. CMV classically is a secondary reactivation, and we get a that shouldn't say vasculitis, that should say ventriculitis. It causes inflammation of the ventricles, and we get a ventriculitis. Measles can cause lots of different infections, but the classic one with white matter is subacute sclerosing panencephalitis. So you get your measles, and then a couple of years to decades later, you can get essentially like a reactivation where we get measles in the brain causing progressive encephalitis that's quite slow. And that's probably going to be on the rise again. Now, these bacterial and amoebic infections classically cause a lot of inflammation, but changes with contrast. So we see a lot of contrast enhancement. So we see nodular, chunky, granulomatous inflammation, etc. Viruses, on the other hand, tend not to cause too much contrast enhancement and breakdown of the blood-brain barrier. Rule of thumb, but generally if we're seeing a complete lack of contrast enhancement, we think it's more likely to be a virus that's infecting specific nerves and tracts rather than bacteria and fungi, which is just causing a lot of damage and immune response, leading to breakdown of the blood-brain barrier. So takeaways here. So when someone's immunocompromised, you need to think about what part of the immunocompromised state they are and what we want to test. So if they're on rituximab or natalizumab, we want JC. If they've got HIV, they're profoundly lymphopenic, we think CMV. And we try and cater it. And then always think about enteroviral infections when they've got immunoglobulins are low or they're on B-cell depleter as well. And then mNGS is always particularly helpful in immunocompromised patients because they can have rarer and more kind of unusual infections. Okay, let's talk about deep gray. So here we're in the thalamus, but deep gray also means the basal ganglia as well. So here we're in the thalamus. You can see these are big, swollen, chunky, inflamed thalami. So here we got a 70-year-old man. He's on the Murray River, which is in Victoria. So this is a region in the southern part of Australia, in Victoria. He's camping, he's fishing, develops a headache, confusion, he becomes unsteady, comes into hospital. So we've got confusion, we've got a headache, maybe there's a little bit of meningeal involvement as well, but we've got a protein of 1.25, which is elevated, 63 polymorphia nuclear cells and 86 lymphocytes. General rule of thumb, if you're seeing a very high poly count in your CSF or a decent percentage, 10, 20, 30%, we need to be thinking about infections. There are other autoimmune causes that can do it, and autoinflammatory causes. So these are, things we'll talk about in the other lecture series we do. But when you see poly, just stop for a second and think, we're dealing with an infection until I can prove otherwise. So we've got 63 polys, PCR negative, everything else comes back negative. This is his MRI scan. Look very closely at the MRI. We've got the flare on this side, we've got the T1 on this side, and we've got the diffusion restriction here, the DWI. There's a little few white dots here, nothing specific, but look at the back here in the thalamus. Do you see how that's bright? Now your deep gray structures, and especially the thalamus, should not look this bright. And you can see it's very bright in the posterior aspects, where we say the pulvinar, as well as the medial aspects of the thalamus as well. And if curiosity strikes you, please subscribe and look at our neuroanatomy series, where we're understanding neuroanatomy. And then you can actually correlate that with disease processes that we're dealing with here. The golden rules of neurology is your examination tells you where the lesion is, and your history tells you what the lesion is. And so here, we're dealing with some sort of thalamic lesion here, nothing coming up on contrast, and nothing coming up here on the diffusion restriction, so not a stroke or anything. So we're thinking symmetrical, bilateral, no contrast. Always think of viruses. They're infecting the same tracts going up into the thalamus itself. Essentially, this man has a arboviral infection. Whenever you see something that is bilateral thalamus, you need to immediately think about flaviviruses and arboviruses. Always, always, always think bilateral thalami, flaviviruses, arboviruses. So here, what are our arboviruses? This man ended up having Murray Valley encephalitis while he was on the Murray River in the Murray Valley, and then developed it. So that's what helped us narrow it down. But JEV, which is now in Australia, but is the probably largest and most common virus causing an encephalitis around the world, almost endemic within Southeast Asia and Asia as well, causing huge amount of fatality. Thankfully, the vaccination has now reduced that significantly. Now, wherever you live in the world, be it the US, with the West Nile, etc., there are lots of flaviviruses, and they tend to cause that similar picture of bilateral thalamic, and Nipah can do it as well. Now, we can also see it with rabies. Now, rabies will keep coming up again and again and again, but we can see it with rabies. And so rabies, we think brainstem, deep gray, and we think about temporal lobes. And then finally, TB and rickettsia. ANE, so acute necrotizing encephalitis, is when you get influenza A. After you get influenza A, while you're still infected with influenza A, you can get an encephalitis or an encephalopathy, and you get bilateral thalamic and midbrain involvement. This is not the infection, this is not the influenza, but it's a complex system where we suddenly get a cytokine storm from the infection, and there's some level of inflammation that occurs in the brain, and it's closely related to a mutation with RANBP2. So RANBP2, the patients who have this will develop this hemorrhagic encephalitis and necrotizing encephalitis. So you treat these patients like an autoimmune process. It's not technically para-infectious because they present with the influenza A. And it's not an autoimmune immune response. It's more of an inflammatory cytokine storm that occurs. Okay, so bilateral thalamic, think flavivirus. Flavivirus, PCR does poorly. The reason PCR does poorly is this is the classic situation where you get the viremia, you feel a bit achy and headachy. Mosquitoes. I'm actually in JEV. I'm on holiday. This is actually JEV territory, so I have to be careful. You get bitten, so I just got bitten by a mosquito on my foot right there. I will have a couple of days, and then I'll start getting a headache and feel achy and joint pain, and that's when I've got the viremia. But by the time I actually present to hospital with the encephalitis, it's spread into the CSF, spread into the parenchyma, spread into the thalami, and then I'm unwell. So if I sample the CSF in the blood, I will actually be PCR negative, and that's why we have to send off serology on the blood and the CSF to see and repeat it to see this convalescent titer increase. Now, if I'm immunocompromised, let's just say I'm organ transplant patient, I'm on multiple immunosuppressants, I can't suppress the virus. And so the virus is continuing to replicate, and you may not mount a serological response because your immune system's not working. And in these situations, we send off PCR. Rule of thumb, send off both. Now think about A&E, especially when you have a respiratory viral infection. It doesn't have to be influenza A. And then always remember mNGS doesn't do well in these situations. Okay, Rhombencephalitis. So most common cause of Rhombencephalitis, which is a brainstem encephalitis. You can see here in the brainstem, this was a patient of mine with these little cystic, inflammatory, microabscessi-like lesions. The most number one cause is Listeria, okay? Listeria has a huge propensity for the brainstem, and it can present in a subacute manner, so it doesn't have to come like that. Usually in patients who are immunocompromised, pregnant, elderly, but it can absolutely occur in immunocompetent patients as well. Patients present essentially with the bacteria spreading retroaxonally through the facial nerve back into the pons. It can sometimes do it on the 8th cranial nerve as well. So they present with the facial droop after feeling a bit headachy for a couple of days, maybe some fevers. Then they drop their GCS. If you do an MRI, you can see a lot of pontine involvement, and they have this inflammation. Blood cultures is the test of choice because most patients are bacteremic, and we want to do blood cultures before we start antibiotics on these patients. So immediately send off those blood cultures. Cultures off the CSF can be very difficult, very fastidious organism, and PCR can be sent as well. But again, even though PCR is better than BioFire, it's still a low sensitivity. So you really want everything going for you. Not many places do Listeria cultures anymore. And in the brainstem, we're seeing enhancement, little abscesses, and we want to treat these patients with benpen or ampicillin. And that's why when you are covering someone for a meningitis, you usually would start ceftriaxone, 2 grams BD. But if they are immunocompromised, pregnant, they have the risk factors, we add Listeria coverage as well. And despite that, it can still carry a very high morbidity and mortality. Okay, a couple more cases. Here we have a patient who's heavily immunocompromised, very heavily immunocompromised, and they're hypogammaglobulinemic as well. So this is a ticking time bomb already. Not every immunocompromised patient gets a neuroinfectious diseases, but I'm doing a neuroinfectious talk, so this is a time bomb that's just waiting to go off. 7-month timeline, starts falling in June, difficulty raising from a chair in September, bedbound by November, transferred in December from private rehab, and then neurology gets involved in January. So unfortunately, a very long delay. Now, investigations, she's got a very mild pleocytosis of 6 white cells. Nothing else is positive or comes back. This is their MRI. So we can see here very subtly on the flare signal, we've got enhancement of the corticospinal tracts as they're making their way from the primary motor cortex down the internal capsule, sliding in between the basal ganglia and making its way to the crus cerebri. You can actually see that marked out. Again, look at our neuroanatomy series if you want to learn all of the neuroanatomy here and correlate it with these talks. Crus cerebri, very intense diffusion restriction. This is in the midbrain. And down when we come to the pons, these are the pyramids. This is exactly where the pyramids live. And you can actually see why they're called pyramids, because they're kind of triangular. So this patient has pure corticospinal tract involvement, bilateral, symmetrical, no contrast enhancement. We're thinking of a virus. We have to think of a virus in this situation. So what virus is this? This follows the corticospinal tracts all the way down the spine. You can see this is on the lateral aspect of the corticospinal tract as well. Human Peggy-Virus 1. This is Peggy-Virus infections. What is Peggy-Virus? It is another Flavivirus. Very common. 750 million people infected worldwide. We usually thought it was non-pathogenic, but there's this new entity that's coming out called PAM, Peggy-Virus-Associated Encephalomyelitis. It has a tropism for astrocytes and microglia, so the support structures around the nerves, and it just independently replicates, and it causes bilateral, symmetric, optic tracts, corticospinal tracts, and this propensity for the pyramids. So when you see that, you got to think, is this Peggy-Virus? And it's specifically in immunocompromised patients. It's very similar to the mechanism of how JC virus works and causes PML. So in JC virus, this is a ubiquitous polyoma virus, harmless. 60% of the population have it. But if you're chronically immunosuppressed, we have constant viral mutations that are occurring. Those mutations mean that the structure of the actual virus changes and it becomes neuroadaptive. It can then spread to the brain and infect oligodendrocytes, causing progressive multifocal leukoencephalopathy. And it's very similar theory, and again, a very new virus, a very similar theory that's come out with PAM, ubiquitous Flavivirus. It's harmless, but then with chronic immunosuppression, we have CNS mutations and accumulations that lead to neuroinvasion. So, long story short, Rhombencephalitis, we think Listeria, Listeria, Listeria. We can see Whipple's, Melioid, and TB doing this. And then with viral causes, HSV1 is still very common, and we can see it with our Flavivirus, enteroviruses, rabies, and PEGI. So if you've learned anything from this lecture, always think HSV, always think herpes, enterovirus, Flavi, rabies. Those are kind of like always your viruses that you think about. So always think about Listeria, send off your blood cultures. Viruses, we're always thinking of those three. And with the immunocompromised patients, when we see this new syndrome, I want you to think about PEGI virus. Okay, last one, cerebellitis. This is a very quick one. CVID, treated with IVIG, but develops this progressive cerebellitis, and they've got a CSF cytosis, everything's infectious, is worked up. These CVID patients are complex because they can have autoimmunity as well as a risk of infection. They're an immunodysregulation syndrome. And so given the extensive workup and everything came back negative, cyclophosphamide was started, but the patient continued to progressively get worse and they died. And on autopsy, we find enterovirus. So remember, just because it's not in the CSF doesn't mean that it's not there, and it certainly can be in the parenchyma. In cases like this, things like brain biopsy might be an important aspect, especially with CVID, especially with immunocompromised patients. So for cerebellitis, we think VZV in children. We can think about West Nile virus. Powassan is a flavivirus, arbovirus that causes significant cerebellar edema. Mumps can do it. There's a condition called JC virus, granular cell neuronopathy. This is JC virus, but it's not causing PML. It's infecting the cell bodies within the cerebellum. We usually see it in persons living with HIV with very low CD4 counts, and it causes the cerebellar degeneration as well. And then we can have para-infectious causes. So EBV and Mycoplasma pneumonia, specifically Mycoplasma, causes a lot of autoimmune and para-infectious syndromes, cold agglutination, etc. And so certainly it can cause a para-infectious cerebellitis as well. So take away enterovirus and CVID. Always think about enterovirus when you've got a primary antibody or just a secondary antibody deficiency. Just because the CSF is negative doesn't mean it's not infectious. Always think of the parenchyma. And the same with mNGS. If you brain biopsy them, then you'll see it. If you CSF, then you may not see it. That's it. That's the take-home message, okay? So when you think about infections, and again, this is a long series. I can't put everything about neuroinfections into 45 minutes. But what I want you to think about is, think about it as a syndromic approach. How is the patient presented? What does the MRI in the syndrome look like? Can I narrow down the differentials based on the contrast pattern, based on the symmetry, and then look at their travel history and their immunocompromised status and their immune status, and then try narrow it down and send off the appropriate investigations, understanding the caveats. I've got hundreds of different lectures to do with neuroinflammation. So this plus other areas in neurology, we'll be doing some masterclass sessions. So don't forget to subscribe. Don't forget to tell your friends, and join us next time for the masterclass or the clinical neuroanatomy series as well.